Hello and welcome to today's session. We'll start today's session with a small story. It happened in May 2014 in a district hospital in Nilambur in Malappuram district of Kerala. A lady medical officer was sitting in the busy OP. A 46-year-old woman from the Kartunayagar tribes, the Nilambur Reserve Forests of Malappuram. She came to the OP with a history of fever and headache and myalgia. The medical officer thought that this could be like any other viral fever and she prescribed medicines for the lady, asking her to come back if she didn't have a relief of the symptoms after 3 days. So, after 3 days, this lady returned back. This time, she presented with complaints of severe body pain all throughout her body. Thus, she also said she had bleeding from her gums and she had hematemesis. So this lady was admitted and investigated. From the history, the lady medical officer also found that a week back the lady had noticed a dead monkey lying on the side of the road. Suddenly it struck the lady medical officer. Hemorrhagic viral fever, a dead monkey. Could this be monkeypox? So she notified the disease to the district medical officer and the surveillance officer, and in a few days there was a team there at Malappuram, including the scientists from the National Institute of Virology, the veterinary, and the health department. They investigated the case and came to the conclusion that this is Kyasanur forest disease or monkeypox, reported for the first time in Malappuram. So let's move on to the rest of the session. What is this Kyasanur forest disease? Kyasanur forest disease is a viral hemorrhagic fever that is, sorry for the interruption, it is an acute febrile illness that is known for the past 70 years. So the first case of Kyasanur forest disease was reported in 1957 in India. It was reported in the state of Karnataka. It's a zoonotic disease, and until 2012, this disease was endemic only in the state of Karnataka. But later on, we find that several other states also reported Kyasanur forest disease. So, this is an emerging tropical disease which is being transmitted to newer areas of the country. As we said earlier, this is also known as monkey fever. So, in short, it is an acute febrile illness like any other viral fever, but we may have hemorrhagic manifestations for the disease. How is it caused? The causative agent is a KFD virus, Rhizome disease virus. It is an arbovirus which belongs to the Flavivirus genus, Flaviviridae family. This virus is very virulent because the infection has been reported in laboratory and field workers who have been dealing with the outbreak. So this virus is brought to it is brought to the human beings, or it causes disease in the human beings when it is brought by the vector, which is the heart tick. The bite of this tick, the nymph stage of the vector bites human beings, and that is how the virus is transmitted to the human beings through the bite of this hard tick. So the name of this hard tick is Haemaphysalis. The Haemaphysalis is pinigira and Haemaphysalis terturus. So this it is present in this tick, and through the it is transmitted to subsequent generations of this tick by the transstadial and transovarian transmission. You must remember what is transovarian and transstadial transmission. That is, transovarian is passing on the virus from one generation to the next generation. Transstadial is the transmission of the virus from one stage to the other. That is, from the larva to the nymph to the adult, and that is transstadial transmission. Once infected, this tick will remain infective for life. So that helps in the maintenance of the virus in the nature. Then this also affects monkeys, and the monkeys harbor the ticks. They also get the disease, and the monkeys will die of the disease. Therefore, these monkeys are said to be inefficient maintenance force because once the monkeys die, then the ticks will get off their body, and then they will seek another host. That is when the man gets infected. So the death of monkeys can be considered as a warning signal or a warning sign which will indicate that there is going to be a few cases that is occurring in the next few days. So the episodics, when it occurs in the monkey, it results in the mortality of the monkeys. It indicates likely outbreaks, and usually in these endemic areas or the that is you've got this these forest areas along the Western Ghats. This is the place where we usually get to see the Kyasanur forest disease, and it occurs usually during December to June. Sometimes it occurs as early as October, and the ticks will drop as the animal dies and thus generating hotspots of infection. There are also small rodents like rats, squirrels, etc., which can act as reservoirs of the disease. Rodents and some mammals also. Cattle that graze in the forest, they also can bring the ticks into contact with the human beings. There is no person to person transmission of the disease, so we don't see any clustering of the disease. But if you read that article which I suggested earlier, you'll find that they have written about two clusters of the disease. That is, the clustering is not because of the person to person transmission of the disease, but it is because they live, those people live in the same environment and they happen to get the tick bite and the virus is transmitted to them. There is also no nosocomial infection transmission that is reported. That is no transmission from one person to other in the hospital. So that is something we know. Until now, we do not know that there is any human to human transmission, but then we have to learn further on that. So apart from the monkeys, the goats, cows, and sheep, they also may get infected and maintain the tick population. But that is transmission via this cattle is extremely rare, and there is no evidence of transmission via unpasteurized milk. So what we saw in the slides till now is the first about what is the disease and how it is caused. This is the picture which will help you to understand the transmission. That is, we will start with the, so this is the egg, the larva, the nymph, and the adult. This is the life cycle of the tick. So it's the nymphs that usually bite the monkey or via the rodents. The monkeys and small mammals. These are the common hosts of the virus. There is a dead monkey, and it's not that it's only when the man goes and touches that the ticks can come onto the floor, also they can get into the host. And those who live in the forest, for example, this lady was in the beach talked about 46-year-old lady. She lived in the forest and she lived in caves and small, and the other people in those forests, they live in small huts and they earn their living by selling honey and other forest products. They trade it for other products for their livelihood. So they are related to the forest. It's usually those people who are working in the forest who get the disease. So this is the cattle. They can also get infected with the virus, but they play very limited role in the transmission of the disease. So this is the picture of the Haemophilus tick, and that is these are the common monkeys which play a role in the transmission of the disease or get infected. These are considered as sentinel animals. The one is this red-faced, you can see the red-faced bonnet monkey, Macaca radiata. And then see this is another sentinel animal. This is a monkey. This is black-faced langur, Presbytus entinus. So these monkeys play a an important role in the transmission of the disease in India. So, where do we see this disease? We talked about the first incidence of the disease in Shimoga district of Karnataka in the Kyasanur forest. That is how this disease gets the name of Kyasanur forest disease. That was in 1957. Until 2002, this was restricted only to the five districts of Karnataka. Which are the five districts? One is, of course, the first one, which is Shimoga, and then Uttara Kannada, Dakshina Kannada, Chikmagalur, and Udupi. So these were the five districts. Later on, other districts of Karnataka, that is Chamarajnagar district in Karnataka, then Nilgiri district, Tamil Nadu, other states also got reported the infection. Then Wayanad and Malappuram districts in Kerala, Pali village in Goa. So all these other places also which are neighboring the Karnataka, all along the Western Ghat forest, started reporting the disease. So this is the picture. This is a map which shows the districts affected. It's all along the Western Ghats and the forest areas. So in Karnataka, we said Shimoga was the first district which reported. Till 2012, we have Uttara Kannada, Dakshina Kannada, Chikmagalur, and Udupi. Later on, other districts also. And then in Kerala, I think it is in 2013 that we got the first incidence of the Kyasanur forest disease. And then we got it in Wayanad, and then later on, we got it in the district of Malappuram. Then Goa, some districts or some places restricted in Maharashtra also to report the disease, and this Nilgiri forest in Tamil Nadu also report the disease. So these are the areas where we have had the reporting of the disease, but then we do not know if other areas are also affected, which we need to look into. This is again the slide which shows you that the states or the affected, the districts affected, and that is what see 1957 to right to 2012 you have only Karnataka. After that you can see Kerala 2013 in Wayanad, then Wayanad again in 2014, Malappuram again in 2014, then Palakkad and Wayanad district, that is in 2014, 2015, Nelampur, same area in Malappuram, Wayanad. So these areas have now become like endemic for in Kyasanur forest disease. And then in 2017, you have Maharashtra and Goa reporting Kyasanur forest disease. So this is what you got. This is show this plus sign that is about the anti-KFT IgG antibody positivity. They've got it in humans. They've found it in monkeys and in ticks in all these places. That is what the slide tells you. So that is where the cases have been found. So in Wayanad, the first case in 2013, 2014, one case was there. Again in 2015, there were 11 deaths, 214 suspects, 102 confirmed. 2016, there were 9 cases. 2017, we do not have any cases. Then here you can see the deaths due to KFT. So do people die of the disease? The case fatality of the disease is 2 to 10%. And we said that this virus is very virulent and it can cause laboratory acquired infection in laboratory personnel handling the disease, and we also have seen the disease in those people who are investigating the disease for the outbreaks. So that means that this is a virulent virus, and therefore when we handle the virus, we be very careful, and so it is suggested that this virus should be handled only in a laboratory which is a level 4, which has the maximum containment capacity. Okay, where they have safety cabinets, they should be handled only in such laboratories. Who is at risk of infection? We discussed this a little earlier, and those who are, get occupational exposure, mainly the hunters, the herders, the forest workers, farmers who grow the cashew trees and all are known to get the disease. They are potentially at risk of infection if they come to the contact with infected ticks. Now, how do we diagnose? Of course, if the clinical manifestations will give us the clue to the disease. We said it is a viral hemorrhagic fever. The incubation period of the disease is 3 to 8 days, which means that once the person gets infected, the clinical manifestations will develop in around a week's time, and the infection is said to be, or the illness is said to be biphasic. So there are two phases of the illness. What happens in the first phase? First phase is characterized by sudden onset of fever, headache, and generalized body pain, which is we saw in that lady. And the body pain is usually in the neck, upper and lower back, and in the extremities. There are no specific skin lesions or rashes which are observed, which as you see in the dengue fever, it's again another flavivirus, but there are gastrointestinal symptoms like vomiting, abdominal pain, and diarrhea. And hemorrhagic manifestations can be seen in the first phase, begins 3 to 4 days after the onset of symptoms, and these usually start with some oral lesions, maculopapular eruptions on the palate, and conjunctival congestion in the eyes may be seen in almost all cases. Other ocular manifestations like serous discharge may be found, then some vitreous and humor involvement. Sometimes the retina may be affected. Okay, so there are ocular hemorrhages, then hematemesis, that is GIT bleeding can occur. Epistaxis, rectal bleeding, and gum bleeding are also may be present. And if this hemorrhagic manifestations they persist to the second phase of illness, then the outcome of the disease is not that good. Okay, so fever may subside, but patients they can remain asthenic and listless for a very long period. Dehydration may be there. And some other non-specific features like lymphadenopathy, hepatitis B, and megaly may also be there. And then the second phase of illness is after 2 weeks. After 2 weeks. So this first phase may last to up to 2 weeks. Not in all, but some people may get the second phase of the illness. Around 80% of the people will just have this first phase and they will recover from the disease. But 20% of them can go into the second phase. And that is characterized by predominantly neurological symptoms like drowsiness, disorientation, confusions. And then you get elicit Kernig sign, which you see in meningitis. I hope you remember how to elicit the Kernig sign. It is, there will be pain. The person may not, when you flex the hip and try to start straightening the knee, you cannot go beyond 135 degrees Celsius. Sorry, degrees. So that is the Kernig sign. And abnormal ankle reflex. So all these are the neurological manifestations that may be there during the second phase of the illness. When the fever subsides, these mental alertness and the neuron will be regained, and all the neurological manifestations also goes away. So there is very few, or there is not a sequel of the disease. Some patients will have only fever without any neurological manifestations during the second phase. So this phase will last for another 2 weeks. So this is the clinical picture. So you get an acute viral illness with hemorrhagic manifestations, and some of them may go into the second phase, which is predominantly neurological features. And we said if the person has got hemorrhagical manifestations persisting, then the outcome of the illness will be poor. So the if you get symptoms like this and you get to you ask them about from which area they come, and if there's they come from an area which is reporting the KFT illness and along with the clue of their occupation working in the forest, then you should get a clue to the diagnosis of KFT. The specimens that you have to collect is human blood samples. Some that is monkey visceral along with the investigations that you carry in the field. Ticks they may collect from the field. They're tested for the KFT virus. In the acute phase, what we can do, that is in the early phase of the illness, what we do is the real-time RT-PCR, the real-time polymerized reverse transcriptase polymerized chain reaction. Later on, you can get the IgM ELISA positivity, and in the blood along with this, you may also find pancytopenia, that is drop in the counts, all the counts, red blood cells, the WBCs, and the platelets will be low. So the important diagnostic tests that are done is one is the RT-PCR, which is in the early phase, and you get the IgM antibodies, later on IgG antibodies also. So this is the slide which shows you that in relation to the investigation that was done in Nilamur, in Malappuram district. They say that that lady was the index case, and in that lady, IgM ELISA was positive, and also IgG ELISA was positive. And in her family contacts, eight of family contacts were tested. Seven from seven they got the serum, and one of the family contact had IgM positivity. And this is a second cluster because when a detailed investigation was done, they also found that a husband and a wife died around 1 month back. So the husband who had fever first, and that man died. Actually, he did not seek any medical advice, so there was no documents to verify. And after his death, around 1 week or so, 2 weeks or so, his wife also died. With she also had fever, but she also didn't seek any medical advice. So this has to be noted that these people do not seek medical advice. So this could be one reason for mortality. And if you could raise the awareness among these people that they should seek medical help early, that this is a disease which has got fatality. If this awareness is given to the people, perhaps we can save a lot of lives. And in this second cluster also, they have written this index case. What do you mean by index case? Index case is the case that you see get to see first. So primary case means that is the first case that is that in relation to the investigation, that is the first case that is. So here the usage of this primary and secondary may not be very correct because secondary case means those cases which have come from the primary or that is, but in this case there is no person to person transmission. Only that this is the first case that has come, the first case that we noted, the index case, the first case that is was there in that area as a primary case, and then from when they tested or when they investigated, they also got four other people who had reported fever, and from four of them they took the serum, but only one was positive by the RT-PCR. Then in other contacts also they collected the serum of 17, they got one positive. So these are the two tests that are currently being done. One is the RT-PCR, the second is the ELISA, IgM and IgG. So this is a little bit about the biosafety level, which I said that this virus you can check or you can do the test only in a biosafety level 4 laboratory. What are the other diseases which require a biosafety level 4? You must have heard recently we had Nipah, then Ebola, Crimean Congo hemorrhagic fever, and 5H1. These are the diseases which require level 4 lab testing. And at present, we do have this facility only in the National Institute of Virology, Pune, but they have come up with some formulations which can inactivate the virus. And if you inactivate the virus, perhaps you can do the test in a lower level lab as well. So you can read about those details. What is the cause of the illness? We described it a little bit earlier that 80% of them will recover. They will have illness only for 2 phases, the first phase of the disease. But 20% will go into the second phase of the illness, which may last another 2 weeks. And the outcome is poor if there are hemorrhagic manifestations. So convalescent period is prolonged. There is not much sequelae of the disease, but case fatality rate can be up to 10%, which is something that we should be careful about. So if it happens in some naive population, it means it's in a new population where the disease has not been reported earlier. The health may be poor or their immunity levels may not be so high, so the case fatality rate may be much higher. Is there a treatment for KFT? So there is no definite treatment. You can give supportive measures, proper hydration, intravenous fluids, blood products. These can be given based on the need of the patient, based on the clinical features. So this is very important. This is how you are going to prevent and control the illness. There is no treatment for the disease, so prevention is very much important. So being on the vigil when you have to be on the lookout for the disease. So that is how can it be done. So one thing is surveillance, and I need not remind you surveillance. What's the definition of surveillance? Go back and read your textbooks again. So surveillance is the a continuous scrutiny of those factors which determine the occurrence of the disease. So here we know that it is monkey deaths can signal the disease. So this is an event which can alert us. So this is a disease that we can do the event-based surveillance. So look out for these infections in monkeys, deaths in monkeys, and there, usually we do that in the national parks, the wildlife sanctuaries, reserve forests, especially since it's reported along the Western Ghat forest. In those places, the neighboring villages, we can be on the alert. So that is event-based surveillance, and that will help you for the early detection and institution of appropriate control measures. So surveillance is the event-based surveillance is there, but you can have continuous surveillance in monkeys, and also you have to have human surveillance for the early diagnosis and prompting a treatment of the disease. So that routine surveillance is part of the IDSP that can go on, and event-based surveillance whenever there is a suspected case or a death that occurs in human beings. And that is also something called as zero surveillance. Like you can look at the those blood samples and look for the antibodies of the KFT in certain areas, and you can know how prevalent the disease is. So that is also a mechanism of surveillance. Tick surveillance, tick mapping to identify the hotspots, and tick positivity, looking for tick positivity for KFT. So surveillance is very important for the prevention. It's a surveillance in monkeys, in human beings, and in ticks. So this is what is the definition of an exposure zone, potential exposure zone, as per the state of Karnataka's policy. I think that is the same that is adopted everywhere in India. A radius of 5 kilometers from where monkey deaths have been reported is considered as a potential exposure zone, and the control activities will be done in this area, 5 kilometer radius. So how do you control? It's the ticker. How can you control? You can use the insecticides like gamma hexachlorocyclohexane that is only for us close to kill the ticks. So I just forgot to tell you about the how the first case of KFD happened. It happened because of the clearing of this forest. And what happened is these arboreal monkeys, they were all that is, living in the trees, and they got exposed to the clear ground, and that is when they got bitten by the ticks. And so the human activity that destroys the forest, the urbanization, has resulted in the disease. So it is high time that we learn to live in peaceful coexistence with other animals and our and live at peace with and harmony with the nature. Many illnesses that we see today are a result of lack of understanding of this that this earth belongs to also other animals, and that we need to bear in mind. Even when we had Nipah, we had the same issue. So that I just told in between. So we need to, let's say, and they see the concept of one health, which means not only thinking about human health, you're thinking about animal health and all. You can go and read about one health. Or this is now coming up very much, and that is very important also. And malathion spray can be done within 5 kilometers range from the hotspots where the dead monkeys are found. And humans, those who are going to the forest and all, they can use the repellents to avoid getting bitten by the ticks. Repellents that can be used N-diethyl metatoluamide DEET or dimethyl phthalate oil. These can be used as repellents. So you can control the ticks by using insecticides, and you can also get yourself away from getting bitten by using the repellents, also by protecting yourself using clothes, protective clothing you can have all throughout your body. And health education is very important, spreading awareness, better see health seeking and early case detection. So, apart from this, very important is the administration of the KFT vaccine. There is a formalin inactivated vaccine which is available, and vaccination need to be given to those individuals between the age of 7 to 65 years, and that is given in endemic areas. Specifically, around we said the area for action is around 5 kilometer radius of the foci of KFT. So all those people living in these areas will be given this vaccine, and usually it is undertaken as a regular activity in the endemic areas by the states between August and November. Since the disease is seen during December and June, so you would be prepared before December. So August to November is the period when they would administer the vaccine. 2 doses of the vaccine has to be given, that's 1 month apart. The vaccine induced immunity is short lived, so you have to give a booster after 6 to 9 months. That will be the first booster, and then annually these boosters have to be taken for 5 years after the last case that is reported in the area. So that is the vaccine. But this vaccine doesn't have a very high efficacy. If we give it to 100 people, maybe 80% may be protected. So the first dose it's 63%, with 2 doses it is 83%. Also, the coverage of the vaccine is low because the acceptability issues are there. So these are the things that we need to study. How are we going to improve the coverage of the vaccine? Why can you come up with vaccines with greater efficacy? These things need to be studied further. So that is about the prevention and control. In short, surveillance is important. Then control of the ticks using insecticides. Then getting protecting yourself from getting the bites by using repellents and protective clothing, and then health education we said, and the last but not the least, five control mechanisms, mainly the vaccine, fifth one. So this is about, in short, about Kyasanur forest disease. We looked at what is the disease, an acute hemorrhagic fever that is caused by KFT virus. The monkeys have got a very important role in the transmission of the disease. And we found which are the areas along the Western Ghats, the forests along the Western Ghats. People get affected. And what are the clinical manifestations in the biphasic illness? And if the case fatality is around 2 to 10%. Then we saw the five control measures that we can take for the prevention of the disease. So we will conclude today's session with what are the gaps in the knowledge of the Kyasanur forest disease. These are the areas which the youngsters like you can take up for further studies. You can look into it, whether there is person-to-person transmission of the disease, the biphasic nature of the illness. Only some people, we said only 20% go into the second phase of the illness. Who are those people who are at risk of going into the second phase of the illness? We talked about the diagnostic tools, but we need blood. And in the field, if you have to do investigations, it is not very easy. You require a biosafety level 4 lab. So what can you evolve some point of care diagnostic test which can be used in the field? This needs research. Better vaccines. We said the efficacy of the vaccine is not that high. So can you look for vaccines with better efficacy? How could you improve the coverage of the vaccine? That is, how could you increase the acceptability to the people? Is it then is the disease prevalent only in these areas along the Western Ghats, or is it there in some other parts of India and elsewhere? The disease is there in China, I think, some other places also. But in India, do you find it in some other places that you can look into it, and there's a scope for research. So you can do some zero surveys too in those areas and try to find out whether the disease exists in your areas. What is the clinical to subclinical ratio? Those all those who get infected, do they manifest the disease? We need to find out. Then, why do some people develop hemorrhagic manifestations and biphasic illness? We already talked about. So, these are some areas which you can take up for research. So, so with that, I think we will conclude today's session. And last, I will stop with this quote. To bring about a world in harmony with nature, we must be her. We must be her conscious. Each one of you, each one of us must be the conscience of our nature and worthy guardians of nature. We must be guardians. We must be protectors of our nature. And we have to learn to live in alignment with the natural order. Thank you.